Good afternoon. I'm Jennifer Shaw, and I am from South Central Foundation in Anchorage, Alaska. We've heard about two wonderful community-based programs and efforts, and I'm going to talk with you about a clinical system, an Alaskan Native healthcare system. Is this the clicker?
Yes.
Okay. Green means go, I'm assuming. Okay. Or not. Okay. So just briefly, you'll see lots of maps of Alaska today. The Alaska Tribal Health System is made up of a total of 30 different Alaska Native-owned healthcare systems, but primarily these 12, which are the regional systems. And in the area, do I have that right there? This area right here, that's Anchorage, where that red star is. And this sort of dark blue area covers the South Central Foundation region. We go up to the Canadian border near Tok, and we actually also serve the Pribilof Island of St. Paul and several other outlying villages. But this is our area. It's 107,000 square miles, just to give you a sense of the distance. Okay, so here's another just way to think about the distance that we're talking about that becomes relevant in service delivery. So if you overlay the state on top of the contiguous 48, you're basically covering over 1/5 of the land mass. About 740,000 people in the whole state. So in Anchorage, this is the Alaska Native Health Campus. It's made up of 3 organizations, the South Central Foundation, with our newest building going up that will be a child health care specialty building that is will be the only one of its kind in the country, and the Alaska Native Tribal Health Consortium on the left. Together, we co-own the Alaska Native Medical Center, which is the tertiary center for 160,000 Alaska Native and American Indian people throughout the state. South Central Foundation is very proud of the fact that this last year we won our 2nd Baldrige Award and recently hosted the Surgeon General. This is our primary care center. So I'm just kind of trying to orient you to our system, and I'm still not pushing the right button. Oh, there we go. So just so you know what that replaced, this is what that replaced. This was the healthcare system, this was the building, I should say, that housed the healthcare system that was run by the Indian Health Service until about 1997. South Central Foundation has a vision of a Native community that enjoys holistic wellness and a mission of working together with the Native community to achieve wellness through health and related services. I'm going to skip through some of these quickly in the interest of time. So the NUCA system of care is a patient-centered medical home model of care. I forget what level we are, but it's the highest level. I think that's still 3. And it's focused on continuous relationships between customer owners, and customer owners in our healthcare system are the people that might be called patients in other healthcare systems. And it's also focused on a longitudinal journey to wellness, so across an individual's lifetime as well as across a family intergenerational spans of families. Customer ownership is important because as members of the tribes that own the healthcare system, the people who receive and seek care actually do own their own healthcare system as well as receive services from it. And it's really important at South Central Foundation, the underlying philosophy that customer owners and providers are in a shared relationship with shared responsibility. Another key component of the healthcare system is the integrated care teams. You see here one of the areas where a primary care provider works alongside their nurse case manager, their certified medical assistant, their dietitian, a behavioral health consultant with co-located psychiatry and pharmacy. It's a comprehensive behavioral or primary care system with, I'm not going to go through all of these, but it's quite a suite of services. And in addition to those services in Anchorage, there are 6 community health centers in the hub communities that serve the rest of the 55 villages that are mostly accessible only by plane or boat. Behavioral health care services comprise about 13 specialty programs that include integrated brief intervention in primary care with, as I said, co-located psychiatric and pharmacy services, as well as a long list of specialty outpatient services that include both IOP and residential treatment for substance use issues, as well as residential treatment for youth, day treatment for adults with serious mental illness, and a number of other services, including intensive case management and behavioral health aides in some of the villages, who are the behavioral health care provider for their entire village. Speaking of paraprofessionals. Integration is key. So Behavioral Health Division has a number of support services, including the Research, Evaluation, and Data Services Department that I work in. Our system is very, very data-driven. We have a data mall with internet access for all employees, and we are constantly being asked by our leadership to provide more data. We also have an independent research team within the department that is largely funded through NIH and other federal funds. So, as you've already heard, Alaska has the highest rate of suicide in the nation, although we go back and forth a little bit on that. But with our population having a large percentage of Alaska Native and American Indian people, they are disproportionately represented. Jim said that it's not an Alaska Native problem, it's a problem in some Alaska Native regions. I would just tweak that a little bit to say it's even more of a problem in some Alaska Native regions by far. But even in the region I live in, the rate, which is one of the lowest rates in the state for Alaska Native people, it's twice the national average. So in the first decade of this century, at least one suicide happened in each of 179 different communities out of 280 plus communities. Well, it's the 10th leading cause of death in the nation. It's the 5th leading cause of death in Alaska. And that's consistent. It's not just in 2015. Reducing the incidence of suicide is a corporate initiative of the health system that I work for. And we've taken a number of steps towards meeting that goal, including initiating the Behavioral Urgent Response Team, integrating behavioral health into primary care, a depression collaborative in the early part of the century that led to that behavioral integration, the finalization of a suicide prevention plan, and just this year an MOA to share data with the state of Alaska, which is huge for us because our beneficiaries may or may not be receiving care within our health system. So in the specific services that are focused on suicide prevention include Koyana Clubhouse, which is a day program for adults diagnosed with SMI, as well as that co-located integrated care that I mentioned. Not only is it in primary care, but also in Covenant House, the adolescent homeless shelter, and Brother Francis Shelter, which is the shelter for adults. We have a specialized suicide prevention intensive case management program called Dinayits, and I mentioned the urgent response team, as well as traditional healing and complementary medicine. So the research that we've done at SCF on suicide prevention differs in large respect to that that was described by my colleagues, in that it's clinical. And so we really do focus on that population that we see in the healthcare system. We've looked at a number of things, but currently I will say that we are testing a culturally tailored version of Caring Contacts with Kate Comtois and 3 other tribal sites in the located in the lower 48. SCF will be the largest by far site in that study. We're also about to embark on applying Dr. Greg Simon's predictive algorithm, or I should say the Mental Health Research Network's predictive algorithm that was validated in the MHRN's large population to our smaller population to see if it actually can be validated, or whether we need to look at building a population-specific algorithm. But even more relevant than that, I would like to say, is thinking about the ethics as well as the logistics of how such an algorithm would actually be employed if it were validated, which is a huge ethical question that I think we need to start addressing as a community of researchers and practitioners. And suicide attempt surveillance using EHR data, of course, is part of that. We're also about to embark on a cultural tailoring process of Kate Comtois and Rick Reese's Preventing Addiction-Related Suicide, which is a module for intensive outpatient programs on suicide prevention to raise knowledge and awareness about how to seek services for self as well as loved ones who may be at risk. So the challenges are early detection. As we've talked about, and I'm repeating a lot of what other people have said, many of those who are at highest risk, young, healthy men, aren't coming in for healthcare services. And so we can do everything to tighten our system and make it as systemically focused on prevention as possible, and we're still not going to reach the majority of those at the highest risk in this population. So while I agree that it's important to focus on settings, I still think we need to focus on subgroups at the same time, and we need to think in terms of both and, more than either or. What Jim and Allison are doing in the community is critical, and what happens in the clinical settings is critical as well. And we need to figure out how to work together. We also have the challenge of distance. So you saw those rural clinics and the span of distance. This is an incredible challenge for us. We do a huge amount of telemedicine. Alaska has probably the most sophisticated telemedicine resources in the country, but providing suicide prevention to somebody who's living in a village that may be 500 miles away from the urban center and maybe has one behavioral health aide available in the village is a critical issue. And then gaining support for building culturally driven evidence base is really important for all the reasons that have already been described. And some of the lessons that we've learned, I think, in the work that we've done is that trust must come before treatment. So whether you're doing community-based work or clinical work, that the relationship is the basis for any healing process or intervention or prevention that's going to happen. And with communities that have experienced historical trauma and mistreatment and maltreatment by researchers as well as clinicians, to be honest, and have very clear memories of that, it is essential to engage in a relationship before trying to do anything else, and for that to be continuous and ongoing, for communities to be treated as partners and teachers and researchers, and to be focused on capacity building. So the research department that I work in has 70% of the staff that are Alaska Native or American Indian. We have 2 of our master's level researchers who started PhD programs this fall, and 1 who's about to go off to medical school. So building that capacity so that the research is being done from within the community is critical. I like to remind people, although I'm not a Native researcher, I hope that someday I can put myself out of a job. I think it's important. I try to remember the saying, nothing about us without us. So if we're not actually working alongside people from within the communities that we are intervening in, then we need to maybe rethink our strategies and think about how we can be partners. And then the multi-level intervention approach is critical. So in addition to targeting interventions and developing interventions for individuals, we need to be focused on family as well as community and societal interventions. I just want to give a shout out to Michael Chandler's work, which is probably, it's a bit dated at this point, but I think still very, very relevant in that I was interested in, Allison, to note that the White Mountain Apache just elected, I think, their first woman chief. And in Michael Chandler's work with First Nations, when he looked at community-level protective factors, one of the 5 or 6 protective factors that he identified in low incidence communities was the presence of women in leadership positions. So maybe our country is in the process of trying to heal a little bit in that way as well. We can hope. Thank you very much. Thank you for having us.